Hello everyone, and welcome to the Advanced Care Planning Education session. My name is Heather Kilgore, and I am a clinical nurse specialist supporting systemic therapy at BC Cancer in Vancouver. I've done a lot of thinking about advanced care planning over the past few years, and I'm excited today to deliver this content alongside some of my lovely colleagues. I'd like to acknowledge that this education was developed in close collaboration with the BC Cancer Clinical Nurse Specialist workforce, as well as the Nursing Advanced Care Planning Working Group. So welcome. I respectfully acknowledge the inherent rights of First Nations whose ancestral territories span every part of what is now called British Columbia, and these include unextinguished land rights as well as the rights to self-determination, health, and wellness within their territories. For thousands of years, their laws and governance systems have upheld their sovereignty, which remains recognized in provincial, national, and international law. We also honor the rights of Indigenous peoples from other parts of Canada and beyond who call these lands home. And as nurses and leaders, it is our responsibility to recognize the ways in which the healthcare system has and continues to harm Indigenous people and work to deconstruct and rebuild the system to create culturally safer and anti-racist care for Indigenous peoples. These responsibilities are mandated by provincial law through the BC Declaration on the Rights of Indigenous Peoples Act, or DRIPA, and by our BCCNM College Practice Standards, meaning it's a professional expectation of all nurses. If these laws, terms, or standards are new to you, it is the expectation you will seek out resources to learn more, as we are all part of this work and responsible for action. As we delve into the topic of advanced care planning, we must approach this with cultural humility, curiosity, and respect, entering the process in relationship with our patients and families. Our intention for this session is to create a culturally safe space for open and respectful exchange as we explore advanced care planning. We aim to share knowledge, teachings, and opportunities to learn from one another, guided by mutual respect, humility, and understanding. We come to this conversation with open minds and open hearts, recognizing the importance of honoring patients' voices, values, and cultural identities in advanced care planning. We encourage and invite you to lean into this conversation, reflect deeply, and engage in a way that supports trust, relationality, and culturally safe care. Together, we can strengthen our practices to ensure advanced care planning is meaningful and responsive to the diverse needs of all clients. The objective of this education session really is to define advanced care planning and encourage folks to approach ACP with cultural humility by ensuring advanced care planning is culturally safe and free from racism and discrimination, including Indigenous-specific racism. And an important step in ensuring we are providing that culturally safe advanced care planning, we must first engage in that critical self-reflection. So before we get started, I really want everyone to consider the question on the slide. So how does my cultural background, values, and experiences influence the way I approach conversations about advanced care planning? So what is advanced care planning? Advanced care planning is the process of thinking about and recording your values, beliefs, and wishes for future health and personal care, and sharing these wishes with the people you trust in your healthcare team. Components of advanced care planning may include planning for when you can no longer speak for yourself, reflecting on what matters most to you, and writing down wishes in documents such as advance directives. The visual on the screen here is from the BC Centre for Palliative Care, and it provides us a high-level overview of advanced care planning, situating it as a three-part process comprised of think, talk, and plan. So beginning with the blue box, or think, individuals are encouraged to reflect on what matters most to them and who would make decisions for them if they could not. You then move towards the purple box, or talk, where individuals are encouraged to discuss their thoughts with the people they trust in their healthcare team. And then that final gray box is plan, where wishes are actually recorded and shared. Importantly, in the middle of the model, we have the circle labeled review, with the arrows really demonstrating that iterative and ongoing nature of advanced care planning. So as we know, an individual's values and preferences may change over time, and as such, really advanced care planning should begin early, but also be revisited regularly, allowing patients the opportunity to express their preferences towards treatment and actively participate in decision-making throughout their care. An important component of advanced care planning is naming your substitute decision maker. A substitute decision maker is someone who makes health and personal care decisions for an individual when they're unable to make those decisions themselves. Importantly, a substitute decision maker's role is to make decisions on behalf of what the patient wants, not based on what they themselves would want. When considering who you might want your substitute decision maker to be, you might choose someone who knows you well and understands your values, beliefs, and wishes, someone who will honor your wishes even if they are different from their own, someone who can communicate with healthcare providers and advocate on behalf of you, and someone who's willing and available to take on the role. Patients can legally select their substitute decision maker by completing a representation agreement. And although representation agreements are legal documents, they do not require a notary or lawyer and do not cost money to complete. You can simply print one off online, fill it out, and have 2 witnesses sign it for the document to be legal. If an individual does not choose to complete a representation agreement, there is a list defined by BC law to make sure that everyone has someone to make decisions for them. So that's the list on the right of the screen here. So as you can see, if you haven't selected your substitute decision maker, it'll first default to your spouse, then to one of your children equally ranked, a parent equally ranked, etc. So essentially the healthcare team will move down that list looking for the first person who is willing and available to be your temporary substitute decision maker. What's really important to emphasize here is that once you've decided who your substitute decision maker will be, you need to make sure that they're prepared to make decisions on behalf of you. And so really what's important to emphasize here is conversations between you and your substitute decision maker to ensure that they understand what matters most to you. In addition to conversations with substitute decision makers, patients may also choose to record their wishes in documents such as an advance directive or a letter to their loved ones. An advance directive is a legal document that provides instructions directly to healthcare providers to give or refuse consent to healthcare treatments. And examples of healthcare treatments may include CPR, intubation, feeding tubes, etc. So patients can independently complete legal documents to give or refuse consent to specific treatments in advance. But we know it'd be impossible for a patient to anticipate and give or receive consent to every treatment option and anticipate every potential scenario. So our emphasis really is on encouraging conversations about a patient's values and wishes that may then inform substitute decision makers in making decisions on the patient's behalf. Should a patient express interest in an advance directive, you can print one off from the Ministry of Health website, and we also would encourage the patient to discuss the creation of an advance directive with their oncologist. The form is also included in the My Voice booklet or the First Nations Health Authority My Care, My Choices workbook. A second option could be something a bit more informal. So advanced care planning can be as simple as recording a video or writing a letter to your family. The BC Centre for Palliative Care has several examples of written letters to families you can share with patients as an example. You can find these on the BC Cancer Advanced Care Planning webpage. You'll see an example on the slide here, and within this letter, that's written from a mother to her children, her adult children, she shares, "If you're faced with a snap decision, don't panic. Choose comfort, choose home, choose less intervention, choose to be together at my side, holding my hand, singing, laughing, loving, celebrating, and carrying on. I'll keep loving you and watching you and being proud of you." And you can see from this example how powerful recorded wishes can be and how helpful they can be in supporting decision makers.
Thanks, Heather. Hi, everyone. My name is Shamana Koo. I'm the clinical nurse specialist for BC Cancer Abbotsford with a portfolio focus on palliative care. And now that we've learned what advanced care planning is, let's watch a video demonstrating ACP and the impact it can have on patient care. As you watch this video, I want you to be mindful about what this brings up for you.
Meet Max, a nurse at BC Cancer. She's getting ready for another busy day. And as she reviews her assignment, she sees her first appointment is with a new patient who was recently diagnosed with cancer, Deep. She sees that Deep indicated he wanted to learn more about advanced care planning on his intake form. Max hasn't had many conversations about ACP yet and worries about how they might go, but she knows they're important. She's seen what can happen when patients' wishes weren't understood or communicated in the past. She winces at the thought and pulls herself together.
Hi, Deep. I'm hoping we can talk about advanced care planning. It's something we do with all patients at BC Cancer to make sure your care aligns with your values and goals. How does that sound?
Yeah, that sounds okay.
Okay, Deep. Let's start the conversation by getting to know you better. What should we know about you as a person to provide the best possible care?
What do you mean?
For example, some people share they really value their job and find meaning in going to work every day. Others tell us about the important people in their lives or the activities they enjoy.
I guess something I value is living well. I'm afraid of feeling so unwell or being in so much pain that I'm not able to go outside or play with my kids.
Thanks for sharing, Deep. We want to understand what matters most to you and what your worries are so we can support you. Moving forward, our team will focus on supporting you to live well by managing any pain you may have and checking in regularly to see how you're doing. How does that sound to you?
That sounds good. I appreciate that.
Later on, as Max reflects on the conversation, she remembers the look of relief on Deep's face. She wonders how many past opportunities she's missed by not talking to patients about their wishes and worries, and feels motivated for her next assessment with Jaylene, a younger patient with metastatic cancer. Max notices that Jaylene looks tired and has lost weight since the last time she saw them.
I'm noticing it seems to be taking more of an effort for you to move around. Would you agree?
Yes, I haven't been feeling very strong lately and it seems to be getting worse. But I'm working on getting stronger.
I hope you will get stronger too. But I'm worried this is as strong as you might feel and that things could get more difficult. I wonder if we can talk about a plan for if things get harder?
I've been worried about that too. I know death is coming, but as things get worse, I'm worried I won't be able to take care of myself anymore and I'll be a burden to my family.
That's a big and real worry. Many people worry about being a burden at end of life. What would not being a burden look like to you?
Well, ideally, I want to stay home as long as possible. But if I can't use a bathroom anymore, I'd want to be somewhere I can get help so my family doesn't have to do everything for me. I don't want to go to a senior's home or hospital to live out my days. I want to be surrounded by my family and my things.
As you say that, a few options are coming to mind for me. The first is home support, where healthcare workers visit you in your home to ensure you're supported. Another option is hospice, a place where you're provided 24-hour care and focus on your quality of life. I can give you more information about these options, and next time we meet, we can discuss them further if you'd like.
Yes, that would be good. I've really been worried about this lately. I'm so relieved to know I have options. Thank you for talking to me about this.
Looking back on her day, Max feels good about starting advanced care planning conversations with her patients, planning for their future, and relieving their worries. ACP can help patients make informed decisions about their health, reduce anxiety, and ensure their care aligns with what they want throughout their treatment. ACP conversations can seem daunting at first, but doing it can make a world of difference in a patient's life.
Pictured here is a visual demonstrating how advanced care planning occurs on a spectrum. People tend to associate ACP with end of life, but that isn't the case. Rather, many benefits of ACP result when ACP conversations happen earlier. You'll see across the different boxes here how our approach to ACP will shift over time, from when an individual is healthy to being diagnosed with a serious illness, to functionally declining, to then end of life. And you'll see throughout the spectrum, we have the integration of a palliative approach to care. Ideally, care planning should begin when a person is healthy. It might occur around the dinner table or on a park bench. You'll see in the first box, this is when individuals are encouraged to begin having conversations about their values, beliefs, and wishes for care, identify their substitute decision maker, and document and share their wishes with their healthcare team, substitute decision maker, and friends. However, awareness of ACP outside of healthcare is still somewhat limited. So looking at the second column of diagnoses of serious illness, such as cancer, patients may or may not have heard of advanced care planning before coming to BC Cancer. If they haven't, we can support them with education and introduce them to helpful resources. Importantly, even if the patient has done ACP prior to their cancer diagnosis, it's important to revisit these conversations, as ACP is an ongoing process. We know a patient's values and preferences towards care are likely to change as their health, age, or functional status changes. We want to emphasize that ACP is everyone's responsibility. Each member of the interdisciplinary team has the responsibility to ensure that patients receive holistic care that is aligned with their values and beliefs. We know that patients want healthcare providers to initiate conversations about ACP during their care encounters, and we want to empower different team members to be able to engage in these conversations, but to do so in a culturally safe and respectful way. Before we start talking about workflows and resources, we want to address culture. Everyone belongs to a culture. Culture shapes our values, beliefs, and ways of understanding the world. Some components of culture can be visible, such as language, but more invisible components of culture can include beliefs and interpretations. It's important to note a person's culture influences how they view health and well-being, how they interpret and respond to their experiences within the healthcare system, and how they make decisions. For example, an individual's culture may influence how they share information. Some may want full details, while others may prefer a trusted person to receive information on their behalf. Furthermore, decision-making is often guided by cultural values, including who is involved and how choices are made within families, loved ones, and even communities. It's important that we, as healthcare workers, create culturally safe environments for our patients. Strategies we may use to do this include practicing cultural humility. This involves being respectful and humble towards other cultures and never assuming what is seen as normal in your culture is right or better than another person's culture. It involves practicing self-reflection, which means acknowledging your own attitudes, assumptions, stereotypes, and prejudices that might affect the quality of care you provide. This is not just in relation to culture, but also things like gender, ability, and age. The next important step is to assess how your culture impacts your intention with others. It involves establishing power-balanced relationships. The patient is the expert on what is important to them. In ACP, they choose what they want to share or are ready to share. This is not about the extraction of information. It's about coming together in relationship to discuss what is important to the patient so that we can help guide the care plan to ensure it aligns with their wishes and values. Cultural safety is not about learning about other cultures, but rather about ensuring that the healthcare environment is safe for individuals from different cultural backgrounds, particularly Indigenous peoples, by recognizing and addressing power imbalances and systemic racism. It's about acknowledging the impacts of colonialism, racism, and privilege, and creating spaces where Indigenous patients feel respected, validated, and supported.
Thanks, Shaman. Waikta, Nikki Rose Hunter Porter and Squest, Dao Sislaquapam Kista Aquin, Tacum Sislaquapam Kamum Twin. My name is Nikki Rose Hunter Porter, and I am Silquapam First Nation with family ties to Statlium, Chilcotin, and Inklakap Nations. And I am Silquapam from Daos, colonially known as Bonaparte First Nation, which is one of the 17 communities within the larger Silquapam Nation. And I live within my homelands of Silquapam Ulu in Tecumseh to Silquapam territory, which is also known as Kamloops. And I am the provincial clinical nurse specialist working within Indigenous health and cultural safety for BC Cancer. And we're going to talk a bit about Indigenous specific anti-racism in the context of advanced care planning. Systemic racism leads to mistrust, delayed care, and poorer health outcomes for Indigenous people. And this does not just affect one isolated event or encounter. In healthcare, it's a cycle that impacts Indigenous communities across generations, leading to broader disparities in health and well-being. Now, how can we address this issue effectively? There are key considerations that can guide our work to improve healthcare for Indigenous peoples and reduce the negative impacts of systemic racism. And we're first going to talk about self-determination. Indigenous peoples have the right to lead the conversations about their own health and wellness journey, and it's crucial that they feel empowered to express their needs in spaces where they feel seen, valued, heard, respected, and comfortable and in control of their own healthcare decisions. And in relation to decision-making, Indigenous communities may often involve the input of their family or their larger community in regards to decisions. And these peoples are vital in guiding health-related decisions as their wisdom and experiences are essential in shaping a person's care journey. So it's really important that we as care providers respect this process and ensure that we are creating environments that allow a more of a relational decision-making process. Indigenous ways of knowing and healing offer a more holistic, culturally grounded approach to health, and we must uphold and honor these practices and incorporate them into mainstream healthcare. which means that we essentially are just giving space for people to practice and approach health in their own distinct way. And this may include traditional healing practices and approaches, the involvement of elders or knowledge holders in regard to systems of care and different practices. So we must be able to ensure that we're creating the space, a safe space, and respecting how these knowledges are then embedded into a patient's care journey. And finally, we must build trust through open, honest, and transparent communication. Indigenous peoples and communities have historically experienced trauma, and they experience ongoing trauma in healthcare settings, and rebuilding this trust requires ongoing, people-centered, trauma-responsive care and conversation. Transparency in healthcare practices, actions, and policy is really crucial to ensuring that Indigenous peoples feel safe, heard, and respected. So by addressing these key considerations, we begin to dismantle those systems of inequity and that have impacted Indigenous peoples, and we continue to build, guide, and foster healthcare environments that are culturally safe and anti-racist. So now we're going to pause and reflect on David's story. And first, I'm going to read David's story, and then we'll move through some of the reflection in regard to David's story and how we would support him through an advanced care planning journey. So David, a 68-year-old elder from Secwepemc Nation, has been diagnosed with advanced lung cancer. He lives in his community and is a well-known storyteller, often sharing traditional teachings with younger generations. David is deeply connected to his culture and finds strength in spending time on the land, particularly in the mountains collecting medicine. David is working with care staff to complete advanced care planning at BC Cancer. During a preliminary meeting, David shares that he feels anxious about discussing his care as he's had negative experiences in the healthcare system, where his spiritual and cultural needs were dismissed. However, he also expresses a desire to ensure his care aligns with his values and cultural practices while supporting his family and understanding his wishes. So David is a Secwepemc elder and carries deep cultural knowledge. So this tells us that David likely is known as a knowledge keeper within his community, and this is a role that is sacred and respected within the community. His identity speaks to a lifetime of responsibility, teaching, and connection to community. But we also learn that despite his respected role, David has faced an immense amount of harm in the healthcare system. His cultural and spiritual needs have been dismissed. So this brings forward the concept of, Indigenous specific anti-racism and the lack of culturally safe care, also known as, cultural harm, which is often invisible in mainstream systems, but deeply felt by Indigenous peoples. What stands out is that David's story is not unique. Many Indigenous peoples walk into care settings carrying historical and personal trauma, including the intergenerational impacts of colonialism and residential schools. And when his care needs are not acknowledged or respected, this becomes a form of Indigenous-specific anti-racism and cultural unsafety in care, where the very place meant to care for him becomes the one where he must hide parts of himself in order to feel safe. Now, David is facing something very vulnerable and personal. He is intersecting with advanced care planning, but how can someone meaningfully engage in planning for their care, death, and dying if their whole self is not seen or respected by the healthcare system? This is why trauma-informed care, Indigenous-specific anti-racism, and culturally safe care and humility is essential. It means recognizing that these past harms will influence how someone might experience the present, especially within clinical interactions. David's anxiety around advanced care planning isn't just about the illness, it's about trust in relationship. When cultural safety and humility are missing, our trust is eroded, and in order to rebuild it, healthcare providers must engage with an immense amount of humility listening deeply and being willing to do the hard work of unlearning those biases, preconceived thoughts, or ways of understanding who Indigenous peoples are in the context of Canadian history, but even within present day. Cultural humility isn't just a checklist, it's a lifelong practice of self-reflection and co-learning alongside diverse and distinct populations of peoples. It means making space for Indigenous ways of knowing and doing, and not just as an add-on or supplemental, but as a core foundation of high-quality care. David's story invites us to ask, how do we create spaces where Indigenous peoples like David feel safe to bring their full selves to our care systems within BC Cancer? A system where ceremony, language, land, and family are seen as a vital and foundational part of a care plan. A space where our elders and our knowledge holders are not just seen as patients, but peoples who hold valuable knowledge and insights that can help us better support them within the care that they receive. Let David's experience ground our reflection and inspire a more respectful, reciprocal, and accountable approach to care, one that truly honors Indigenous dignity, autonomy, and a relational way of being. And now we'll move through some advanced care planning reflections within the context of David's story. And we're going to move through 4 key areas of reflection as we unlearn and learn how to better support David or clients like David through their advanced care planning journey. And the first reflection is in regard to effective communication and process. So this is kind of that clinical and communication strategy. So when we think about what makes advanced care planning meaningful, we have to start with communication. Effective communication isn't just about delivering information, it's about creating a shared understanding. For Indigenous patients like David, that includes making the advanced care planning process understandable, respectful, and culturally safe and appropriate. So in this scenario, we want to think about how health providers can use tools that are available, such as different lanyards, flyers, education materials, and conversation guides, not just as scripts, but as ways to support that help keep the conversation centered on the person's needs, preferences, and that cultural context. A well-facilitated advanced care planning conversation ensures that the person being cared for doesn't just hear what's happening, that they feel included, heard, seen, valued, and understood throughout the entire conversation. The second part of reflection is that patient-centered reflection, so building that trust in relationship. Trust is foundational to patient-centered care, especially in the context of Indigenous peoples who may have experienced harm within the healthcare system. From the first interaction, the approach of the provider really matters. A warm greeting, a moment to acknowledge a person's concern, and a willingness to listen deeply really help create the conditions of trust. For someone like David, who brings an immense amount of cultural understanding and teachings, spiritual beliefs, and lived and living experience to the conversation, feeling empowered to share his values without fear of judgment is key. Clinicians and healthcare providers need to really create that space where patients and peoples are seen as experts in regard to their own lived and living experience. And this includes supporting the person to take part in that relational decision making and not rushing, not assuming, but listening and co-creating a plan that really respects who they are and where they come from. And that third segment of reflection is emotional reflection. So empathy and emotional awareness. Advanced care planning can bring up really strong emotions. Fear, grief, uncertainty, and even frustration. And it's all part of navigating serious illness and planning for the future. So we have to ask, are we tuning in to those emotional cues? Are we responding with presence, compassion, and empathy? Supporting someone through this kind of conversation means creating space for them to express what they're feeling. It also means managing our own emotional responses as clinicians or providers, and really trying to stay grounded and being aware of our reactions and offering a steadiness during these emotionally charged moments. Empathy isn't just something we offer with words, it's conveyed in how we listen to people's, how we sit with them in silence, and how we honor the vulnerability someone shares with us. And the fourth part of that reflection is that culturally safe reflection, so creating that safe space. And remembering that we're not the ones who are in charge of saying if a space is safe or not. That client and that family will be the ones to decide if an interaction or a space within our system is safe. And cultural safety is about more than just being inclusive. It's about transforming care so that Indigenous peoples feel respected, understood, and valued within the healthcare system. So for someone like David, cultural safety includes acknowledgement of his Secwepemc identity, his traditional practices and approaches, and his relationship with land, family, and spirit. And these are not peripheral, they are central to his wellness and his care. So health providers and clinicians really need to engage with an immense amount of cultural humility, asking open and ended questions that invite the person to share what matters most to them. And it's not about having all of the answers, it's about listening without assumptions and responding with care. So when we approach advanced care planning through a lens of anti-racism and cultural safety and humility, we begin to shift the system toward one that upholds dignity, self-determination, sovereignty, honoring Indigenous knowledge systems, and really creating spaces of trust within every interaction. So these reflections offer a pathway for really embedding anti-racism, cultural safety, emotional presence, and patient-centered care into advanced care planning. So when we take the time to reflect on our approach, we grow our capacity to offer care that truly aligns with the values and the needs of the people that we are supporting. Cookschacham, thank you.
ACP conversations are done in relationship with our patients and families. It's a privilege to be trusted with someone's story. To receive this gift, we need to ensure we are ready to listen. It's normal to feel nervous your first few times doing an ACP conversation, but remember, it's a conversation with no right or wrong answers. It's okay to have emotions during the conversation. Be there as a human being, listen and explore. This in and of itself is therapeutic. We are holding space for these conversations to ensure patients have an opportunity to explore and discuss their thoughts, feelings, and emotions. First, it's important to recognize that emotions are natural in ACP conversations. These discussions often touch on sensitive and personal topics, so it's okay to feel emotional. As facilitators, we create a space where emotions can be acknowledged and processed. And remember, this is a conversation, not a test. There are no right or wrong answers here. Our role is to listen with care. It's normal to feel unsure at first, but focus on being present and actively listening. This helps patients and families feel heard and supported. And you don't need to have all the answers. Practice makes better. The more ACP conversations you have, the more confident and effective you'll become. It's about developing skills over time, not perfection. And finally, it's crucial to show kindness and compassion to yourself and your peers. ACP discussions can be challenging, and we're all learning together. By offering support to each other, we foster an environment where we can all grow and improve. Remember, these conversations are about being present, listening, and creating a compassionate space for our patients and their families. As we move to the end of our presentation, we want to highlight some salient points for you to walk away with. Firstly, as we have covered, advanced care planning is about values and beliefs, not just decision making. And it's also an ongoing process that should be revisited over time, especially as the disease trajectory changes. And as we have highlighted throughout, culture and identity shape how people will approach advanced care planning, and culturally safe care is about creating a safe environment for all people, and it involves reflexivity as healthcare providers to address racism and colonialism within the healthcare system. As touched upon, ACP is a responsibility of all interdisciplinary team members. And lastly, ACP is deeply connected with relationality. It's about how we show up for our patients so that they feel respected, heard, and valued. As we conclude this webinar, I want to highlight some of the available resources that have been developed and where you can find them to support you in these conversations. The embedded QR code should take you to the BC Cancer Advanced Care Planning resources for health professionals. Feel free to take a look there for some BC Cancer specific materials that were developed. You will also find some additional resources, such as the provincial My Voice book, as well as the First Nations Health Authority Your Care, Your Choices workbook. We encourage you to look at and familiarize yourself with these resources. I want to take the time to acknowledge my clinical nurse specialist colleagues, some of whom presented alongside me today, for lending their subject matter expertise in systems leadership and leading this work at BC Cancer. I would also like to extend gratitude and acknowledge the Advanced Care Planning Nursing Working Group that was instrumental in ensuring that clinician voices were an integral part of the co-creation of this work. And lastly, I would like to thank all of you for taking the time to show up today with open hearts and open minds to learn more about advanced care planning. Bye for now.